My name is Deborah Carey, and I'm a certified oncology data specialist at Missouri Cancer Registry and Research Center. Today's presentation is about how we can reduce missed cancer cases and improve clinical accuracy using case-finding audits. We'll walk through procedures, tools, and strategies we use at the registry, and most importantly, how these audits can strengthen your facility's data integrity. Missouri Cancer Registry and Research Center is housed on the campus of the University of Missouri in Columbia, Missouri. The Missouri Cancer Registry and Research Center is supported in part by a cooperative agreement between the Centers for Disease Control and Prevention and the Missouri Department of Health and Senior Services, and a surveillance contract between DHSS and the University of Missouri. Missouri is a research state for SEER. Let's take a quick look at what we'll cover. We'll begin by reviewing NPCR Program Standard 1.7, then define what a case-finding audit is and clarify key terminology. I'll guide you through the audit procedure used at the Missouri Cancer Registry, and we'll also discuss how these audits are used in training and quality improvement. According to the NPCR, each hospital-based reporting facility must undergo case-finding and re-abstracting audits at least once every 5 years. This standard ensures that cancer cases are accurately identified and abstracted, contributing to complete and reliable data. A case-finding audit is a systematic review process that evaluates how well facilities are identifying and reporting cancer cases. The goal is to catch any cases that may have been missed and ensure proper documentation. This audit helps us maintain high standards and supports quality improvement at both the registry and facility levels. Here are a few key terms you may become familiar with throughout the case-finding audit. Case-finding, the process of identifying individuals who meet specific clinical criteria, source documents, the medical record disease index, pathology reports, discharge summaries, or imaging, missed cases, cases that meet criteria but were not identified or reported, sensitivity, the ability of the system to correctly identify true cases, case ascertainment, confirmation that identified cases meet criteria based on documentation, and case capture rate, percentage of actual cases successfully identified. Now let's talk about how the audit is conducted. We start by sending an email notifying the facility of the audit. The email contains the audit timeframe, instructions for submitting their MRDI, deadlines, and contact information. After the MRDI is received at Missouri Cancer Registry, the audit team then compares it to the MCR database. Following the comparison, if potentially missed cases are identified, a list will be submitted to the facility for review. The facility adds their findings to the review list and submits it to MCR through WebPlus. A final email is sent to the facility containing a summary of findings and recommendations for improvement if required. When we talk about the MRDI, Medical Record Disease Index, we're referring to the list of diagnoses at a facility. Each entry should include details such as name, date of birth, social security number, encounter dates, and importantly, ICD-10 diagnosis codes. All diagnosis codes must appear exactly as listed in ICD-10-CM. The ICD-10-CM case-finding list is not identical to the reportable list. The case-finding list includes a range of codes that could signal a potential cancer diagnosis. Our goal is to cast a wide net to identify any reportable cases that may have been overlooked. A copy of the case-finding list is added to the Audit Excel workbook in a separate tab. A tool we use in Excel is the match function. This formula helps us compare the MRDI's diagnosis codes to the ICD-10 case-finding list. If a match is found, it gives us the position number of the matched item in the list. If unsuccessful, we get an error. This is our first filter to highlight potential matches that need further review. Here's how the formula works. The lookup value is the principal diagnosis from the MRDI. The lookup array is the ICD-10 case finding list. The match type is set to 0, which tells Excel to look for an exact match. This setup helps us flag any entries in the MRDI that might correspond with cancer diagnosis. To make this function work reliably across multiple rows, we convert the lookup range into an absolute reference using $signs. This means if you copy the formula down the column, it always looks at the same list without shifting. This small change ensures consistency in your results. The values returned in the match column are the row location in the ICD-10 case finding spreadsheet. The cases that match are now ready to be compared to the MCR database. Let's take a moment to highlight a few strategies that turn missed cases into learning moments. Perform a root cause analysis. Identify the reasons cases were missed and patterns where omissions occur most often. Use real examples as teaching tools. Present examples of missed cases and walk through the reasons why they were missed. Show correctly captured cases and highlight the key differences. Reinforce proper use of source documents. Teach staff how to locate crucial data in the pathology reports, imaging, or discharge summaries. And clarify and standardize case definitions. Develop reference materials or checklists that will help staff quickly identify qualifying conditions or codes. Providing individualized feedback and conducting follow-up audits ensures that lessons learned lead to lasting improvements. We also stress the importance of collaboration. Invite your clinical staff and data managers to your registry training sessions. Every missed case represents a missed opportunity for patient care, reporting, accuracy, and system improvement. But we can close the gaps by working together to find every case that matters. Thank you for your time and attention. If you have any questions, feel free to contact me at the email shown.